A very good evening to one and all. So today's next topic will be pen for one. So we'll directly swiftly go to the case. So here we present a case of a 38-year-old male patient who happened to be diagnosed as an acute pancreatitis in Assam with 9 days symptoms of persistent symptoms with the worsening dyspnea. Came to our hospital on July 7th. So on the initial day, he was managed with an NIV and supportive care for his respiratory parameters. And with enteral feeding, we tried to start. So he was not tolerating. So we started him with a NJ feeding. And the initial days, he was managed with a conservative measure and he was discharged. So on follow-up on August 2nd, that is in the first week of August, he developed a low-grade fever and an abdomen pain along with a decrease in urine output and shortness of breath. So we moved on to a CT. So the CCT showed the presence of peripancreatic collection extending into the lesser sac as well as along extension along the left paracolic gutter also. So I'll just replay it again. Yeah. Peripancreatic insurance. And left paracolic gutter also. Parenchyma is still visible. Left paracolic gutter. That day was sick. So we moved on to percutaneous drainage. So we did the first thing we. Oh.
It's nearly 4th to 5th week, no? 5th or 6th week?
Actually, the seventh week.
7th week. 7th week, there's a lot of air pack. It's more than 50% air pack.
50%.
So one should suspect bowel communication. Keeping that in mind only, one should intervene. That would definitely bowel communication in this patient.
Yes, sir.
Again, this such homogeneous material as you seen in the previous patient. This will be some a lot of solid here and there, and percutaneous, whether it will completely cure the patient, we do not know. In this patient, well then I would think of an early surgical intervention, because percutaneous thing, maybe it may tide over for a while, but all that material is not going to drain out. Shankar?
First, actually, it was done in outside. First time we didn't do CT. Second admission only we performed a CT. First CT was already done outside. He was diagnosed with an acute pancreatitis. Bowel. Communication, that collection, pocket wise. Matures.
That's what I feel.
Yes.
I have a question. When you think of a bowel communication, do we give a oral or a rectal contrast? Do we try to demonstrate, or we just assume? I mean, is there a way of looking for it? That is what I want to know.
When the patient is not that too bad, not that too ill, we'll try to demonstrate the bowel communication more. So if bowel communication more, we allow it to conservatively manage. Sometimes the bowel, because large communication will be there. Allow them to manage conservatively. It will drain through the bowel.
We can give oral contrast.
Can we give a oral contrast and see?
And rectal contrast also. To demonstrate any communication with left colon.
Actually, we have removed some endoscopically also through that. The
Correct. Sometimes they can.
Yeah.
It is good also.
Good also.
Possibly it is.
Yeah, we can remove that things also to drain.
The air inside the cavity is not always bad.
Yes. You can manage 10% of cases also like that. The air is there, but it's not that.
This patient was sick. Yes, sir. Yes. So, so initial day we started with the 14 French. As we time progressed, we started to upsize the French, and I'll just move on. So we have placed two drains. One is in the adjacent to the peripancreatic collection, and one more in the left paracolic gutter area. So, like 1 week later, the drain tube was draining fecal material. Actually, initially we were able to bring out some necrosum, but within a period of 5 to 7 days, the drain tube was draining a fecal material. So this was in the second week of August. So we put on the first week of August, and second week of August, the drain tube was draining a fecal material. So can we move on?
Is it de novo chronic perforation, or is it no very dangerous looking brains, very sharp and any one of those gone into the coronation? It was contrast to one of the tubes, whether it's straight going.
So
So the piece is coming out, so just what next?
Initially, there was purulent material. Then it became feculent. So probably it was a de novo.
So we repeated a CT on the same day on August 14, 2022. The upper drain was intact, and we did both oral as well as rectal contrast together. And so as we see, there has been a leakage of the contrast in the descending colon, which is communicating with our collections also. And the second image also it's seen. So the initial pancreatic collection size was in the peripancreatic around 22 centimeter, and in the left paracolic region was around 19.8 centimeter, with the demonstration of leakage of contrast from the descending colon. So emergency surgery was done the same day. He underwent an emergency laparotomy with peritoneal lavage, along with the diversion ileostomy and feeding jejunostomy done in the same sitting to take care of his nutritional requirement. And retroperitoneal necrosectomy was also attempted there in the second week of August. So this much amount of necrosum material was brought out with the retroperitoneal approach. But in the post-operative period, initial days saline irrigation was done in the drain tube, and post-surgery the pancreatic drain was draining necrosum, and the retroperitoneal drain was still draining a fecal material, and the blood cultures also came to be positive for a Klebsiella and E. coli. So infectious diagnosis team opinion was sought, and higher generation antibiotics was simultaneously started, and nutrition requirement was monitored with the feeding jejunostomy with the dietitian support. And by the fourth week of August, there was still a persistence of fever despite cultures turning out to be positive with Klebsiella and E. coli and with adequate antibiotic support. So we started him on polymyxin B. Despite that, still there was a continuation of the fever, and the total counts now raised to 20,000 in the fourth week of August, almost 2 weeks after the first surgery. No, so blood cultures only bacterial only, but prophylactically we were started even on antifungals also, we started the same. But despite that, he was having to have a persistent fever around 101 to 102 degree Fahrenheit, and the total counts were still rising, and CRP also was elevated. The first drain, the drain necrosing was still saline irrigation we were doing, sir. The left lower drain alone, left paracolic drain is still draining fecal material only. Sir? We have diverted. That was very minimal, residual only, sir. Actually, it was decreasing. Drains were decreasing by the end of the second week.
So with such extensive necrosectomy, unlikely there is more necrosum is remaining. So that is unlikely, because this patient sees some bloodborne infection not properly addressed, or even the pulmonary. Whatever, not I think not completely. I don't think now there is some sort of a collection somewhere. It is just the systemic sepsis, which is, I'll not be too worried. I'll, change antibiotic depending on the culture. I'll also look for antifungals and start fungal. I don't know. Shankar would like to image now?
Yes. ICU acquired infections also.
Yes, sir. Obviously, now we have to do a repeat imaging.
Yes.
But that's what I was telling Ubal. Surgery is not a panacea for. You can't. I mean, you can clear the necrosis to some extent, but the retroperitoneal suppuration, especially in the root of the mesentery, all these things cannot be completely drained.
What we manage like that, we manage necrosis, make transgas necrosis, fully, complete drain. It will drain through the stomach, water necrosis. Retroperitoneal also, we leave it open, at least 5 centimeters like that. So, yes, outside, put it back. It's a wide open. Nothing will collect inside.
No, what I'm telling you is, suppose if there is extensive retroperitoneal involvement,
Yes.
then
Leave it. Yeah.
the
leave it
complete
open.
clearance is very difficult. That's what I mean.
Yes, that's very difficult.
Suppose you have a loculated nice collection in the stomach, behind the stomach, that will be
Ideal, yes.
Yeah.
Drain it widely. In the
Yeah.
transgases widely drainly. Retroperitoneal also widely drainly. On both sides, make a big opening. There will be residual collection of things. Allow it to drain.
Now, suppose you have a retroperitoneal collection both on the left side as well as
Both sides.
both sides.
Both sides.
That's what incision you put, sir?
Lumbar incision, lumbotomy. At least 5 centimeters inside.
2 lumbotomies.
Yes. So that my finger can go there, hand can go there inside. Reach the epigastrium also.
So we did a relook imaging on August 25th, where we have even upsized the drain now, and there is still persistent of the necrotic collections there, both in the peripancreatic region as well as in the left paracolic region. But still we waited and we managed conservatively for 1 more week, and we did a repeat CT again on, but because the patient still had a persistence of fever, repeat CT also the section showed the same, and there was some sort of extension to the pelvic collections also was noted, both in the peripancreatic left paracolic as well as some extension to the pelvic region also was there. So there was some 2 centimeter reduction in the size after the initial surgery with necrosectomy done, but still it was around 20 centimeter in the peripancreatic area, and in the left paracolic region gutter it was around 11.8 centimeter. When compared to previous study, there was a reduction in the size of the collection. But clinically the patient was still had persistence of fever, and total counts were still very high despite effectively using the antibiotics, and but nutrition wise he was continuing with feeding jejunostomy. So in view of above measures, on September 10th, around the September 2nd week, we did a second retroperitoneal necrosectomy with the help of a nephroscope, and around 150 gram of necrosome material was removed in total. So after this session, the patient was clinically improving well for the initial 3 days, and but again the fever spikes again continue to jump again. So anytime we do any intervention, he seems to be quite well for the initial 2-3 days. Then again the fever spike starts coming up, and again he starts clinically deteriorating again. So this was on September 19th. We have done the CT and it was showing the same. So from surgeon side, the key management.
But this collection on the right paracolic gutter.
Yes, sir.
Earlier
it was in the left.
All in the left. The entire thing was left. Now something has come up in the right,
left,
which is unusual actually.
From surgical side, the key management, they helped in picking up the colonic leak early, and they tried a minimally invasive approach to remove the necrosome without breaching the peritoneal cavity, and the diversion ileostomy to prevent the sepsis. And the lifeline, the patient was getting his nutrition with the feeding jejunostomy, and nearly 100 days his nutrition was managed with the feeding jejunostomy only. And from surgical, they never be aggressive in removing the necrosome.
But the last one is very dicey.
This point is correct only. The principle of necrosectomy is delay as much as possible before you go in for necrosectomy. Second one is don't try to achieve a 100% necrosectomy. If you try to achieve 100% necrosectomy, you will end up in problems in the form of bleeding or bubble injury. That's actually a very valid statement. The point that I want to tell in this case is this is not a single collection. This is very unfavorable for any kind of treatment because there are multiple pockets of collection, so it will be very difficult. They may need multiple surgeries, but still despite that you'll have a problem. Another point is you are telling irrigation. What is the irrigation protocol? Because you was telling, you was criticizing that the fluid that you are putting in, it's not coming out. See, you can do irrigation provided you have a single cavity and you have 2 drains. Whereas if you have multiple cavities and whatever you are sending it, it may not come out. It may stay back and Sir was telling, now there is a collection in the right paracolic gutter. So irrigation you have to be very careful. And drains are two-way street. It not only brings things from inside, it will carry infection inside.
So fortunately, it was not a right paracolic collection. It was a loculated ascites.
When you do irrigation, you have to stop.
Why should you get ascites at this time? Yeah.
When you do irrigation, you have to stop irrigation 24 hours prior to CT. Otherwise, the fluid which you are given will look like collection.
Now, the issue of surgery, repeated surgery, will make a patient stay in the hospital for 100 days and more. If it is anything less than surgery, they will not be staying this long.
No. Whatever it is, intervention means it needs a multiple sittings, multiple long stay.
I agree.
Even endoscopic or percutaneous.
See, I mean,
this is only percutaneous and surgical. But
two laparotomy, this is a major assault on a patient.
No, I'm not saying laparotomy. Anything if you intervene, it means a long stay and a lot of money and multiple sittings. It will cost the patient as well as the doctor's life and time. So
that's
But in the first imaging, it is not that very clear-cut evidence for a surgery or intervention in the initial sitting itself.
Air pockets with the patient not doing well. Air pockets, patient doing well is a different issue. Not doing well, and it is sort of a non-homogeneous material, percutaneous may not really help, and this is the time where we have to go in.
We did repeat his CT after a while because of the continuation of the fever.
Story continues.
Still pen has to come for one.
Actually, you see the patient is all thin. There's no subcutaneous fat and is completely, become malnourished.
Most of he was in ICU only.
Most of the days he was in ICU. So then after upsizing his tube to almost around 28 French, so we performed our percutaneous endoscopic necrosectomy around the second week of October. From June, July, August, September, we entered around the October second week. So we were able to enter into the cavity and remove the necrosome material in 2 sessions, actually 2 weeks apart we performed, and we were able to remove the necrosome using a help of snare forceps.
Like that Ferrocchio chocolate wrapper, no? That kind of golden hued.
No, but what was the indication for this necrosectomy? The patient not doing well?
He was not doing well, sir. Still there was a persistent of fever.
Look at the necrosectomy. I spoiled the chocolate for him.
So with the help of snare forceps we were able to remove it. Those which were loosely hanging we were able to remove. So in a set of 2 sessions we were able to remove the maximum amount of necrosome material from this drain. Initially, we started in the left paracolic drain in the first session. Then in the second session, we did it both in the left peripancreatic drain as well as in the left paracolic gutter drain.
Yeah, as you say, it looks like that Ferrocious chocolate wrapper, the golden wrapper, right? As if somebody left it there.
So with the help of this drain only, we are able to introduce our gastroscope, and we are able to reach till the cavity end, and using snare forceps we are able to remove the maximum amount of necrosum in 2 sessions, and hopefully he was discharged by the end of October, and he came back to us on follow-up after a 3 months period on February. So we did a scan at that time. Overall, there was a reduction in the necrosum content as well as the collections in the abdomen cavity. So in coronal sections, we are able to appreciate it much better now. So
the colonic fistula healed.
Fistula still.
What is this?
This is the side entry, sir. Actually, percutaneous.
Does he have any abdominal hernia? Abdominal wall hernia? This is the left port side.
Left port side. So by February 2023 on follow-up, he came to us.
Then he had ileostomy, reversal, everything.
Everything in meanwhile, ileostomy reversal.
Even this also required some surgical sort of correction.
No, it healed. So occasionally, for a few months, he will make one phone call. No, 5 ml came out or 2 ml came out. So in fact, we have a picture of him on both occasions. At the zenith, where he was completely contoured, and after when he came, no, he was full of flesh.
So, with this seems to be a multimodality department. So,
the first department should be billing department.
So, with the help of multimodal approach, and we are able to do good for the patient.
Never ever they had a confrontational attitude. Throughout this arduous several months, the mother and the wife of the patient, as well as patient himself, he will smile if he is apyrexial, he will not smile if he is deteriorating. So only 2 things. And then with I think with feeding jejunostomy and immaculate critical care and ID support.
But this is ethanol induced.
Yes, sir. Yeah. He is a chronic alcoholic.
Anand did a wonderful job. No, he did that. No, pen here, and then put saline irrigation. It came through this. So complete healthy granulation tissue.